Are you waiting for anyone more?
I think no.
Okay. So we can start by الكتاب. بسم الله الرحمن الرحيم. الحمد لله. Okay, today we are going to just know the most important flow and how can we make use of it. Okay, other details of course are very important, but it is not the top of our priority. We can read everything, but we need just to give you what you are going to do in your clinical life, starting by bedside teaching, then by exam, which will end by a good achievement in front of the patient if you are alone, which may be soon. Okay, so let us start now. Please, everyone need to mute his microphone unless he need to speak, even me.
Okay, can we start, Doctor? Hello?
Yes, yes.
Okay, so Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So for today's session, we will discuss together about the neurological examination in pediatrics. So I will start off the presentation with the upper limb and lower limb examination in pediatric patient. So this examination is to assess the muscle tone, the strength and reflex, and also the sensation of the patient. So in every examination, we have to start off with inspection. So for inspection, it is actually quite similar to the one we do in adults. We have to inspect for SWIFT. Remember SWIFT? S is for scar, W wasting, I involuntary movement, F fasciculation, and T for tremor. Okay, so here are the list of abnormalities that we can expect to find in patient. So you can see here, there are a lot of abnormalities. So if patient is asymmetry at rest, we can suspect the patient has hemiparesis, can be due to stroke. Opistotonus, I'm sure all of you have heard about opistotonus. It is arching of the back, which we can see in patient with tetanus. So it can be due to bilateral cerebrocortical dysfunction, frog leg, as we discussed last week, we'll see in floppy infant, tremor, myoclonus, atitosis, tics, muscle atrophy, and fasciculation. Fasciculation, if we see, it is a sign of lower motor neuron lesion. So this is actually a sequence of atitosis. Atitosis means without fixed position. So the movement are characterized by any combination of flexion, extension, abduction, pronation, and supination, often alternating. Means that the patient cannot maintain their hand position. You guys can watch a video on YouTube so that you guys can watch imagine it better. Okay, now moving on to the motor system. So remember, when doing neurological examination, we have to remember TPR, ABC. Remember TPR, tone power reflex, ABC, ataxia, Babinski, and clonus. However, ataxia will be covered in cerebellar examination. So for tone For tone, we assess by passive motions of the limbs. For upper limb, we move the patient's shoulder, elbow, wrist, and for lower limb, we move the hip, knee, and ankle. Remember to compare it, one side to another. Okay, and then when we want to when we assessing the tone, we can observe for any abnormalities including spasticity, rigidity, clonus, or hypotonia. So for spasticity, it is actually velocity dependent, means that there is typically increased tone in the initial part of the movement, then suddenly reduce. For example, class 9 spasticity, it is usually associated with pyramidal tract lesions, for example, cerebral palsy. And for rigidity, rigidity is actually it feels rigid, feel hurts all the way. Can be seen in extrapyramidal tract lesion. So for clonus, clonus is the sign of upper motor neuron lesion, and for hypotonia, it is sign of lower motor neuron lesion. So for infant, it actually we need to differentiate between floppy strong and floppy weak. This one is also we already discussed last week. So if the infant is hypotonic, so we need to elicit further whether this is floppy strong or floppy weak, so that we can know this is actually central cause or peripheral cause. So this is actually similar to last week's discussion. Okay, and then this is actually also similar to last week's discussion, the 180 examination that we do in patient infant with hypotonia that we suspect floppy infant. So you can see the examination including the scarf sign, pull to sit, shoulder suspension, and ventral suspension. So this is the picture. I'm sure you are already familiar. This one is a scarf sign. This is a pull to sit, shoulder suspension, and ventral suspension. Oh, yes. Okay, now we already assessed the tone of the patient. We already done with T. Now we move on to P, which is the power or the muscle strength. So assessing power in pediatric patient, especially in small children or infant, is actually quite different from how we assess power in adult patients. We can use the similar technique in older children when they understand our command. However, for younger children and infants, it's quite hard for us to ask for them to resist our force, right? So it's actually a more to an observe and play session with them. So it's actually less formal for us to. It's a less formal session for us to assess the power of the muscle strength in pediatric patient. So for the upper limb, it simply just have the child to reach overhead to grasp a toy. Like we see in the picture, we can ask the child to reach for a toy. So from that, we can actually assess the muscle strength of the upper limb of the patient. See if the patient can reach overhead, means that their muscle strength is normal. We can assume it is normal. And for wheelbarrow test, if everything goes well, we can do wheelbarrow test, which we have the child to walk forwards with their hands while we supporting their legs. But I don't think this is appropriate for us to do in the ward. Okay. And then for lower limb, to assess the power or the muscle strength of the lower limb, just simply ask the child to watch the child to walk, climb stairs, jump or hop. Of course, we have to ask their parents or the child first. Either they can walk, if they can climb stairs, jump or hop. If their parents say yes, they can, then we can proceed by asking them to walk, climb stairs, jump or hop, so that we can assess the muscle strength of the lower limb. However, for infants that they still can't walk or climb stairs, jump or hop, we can simply ask their parents to make them stand with while supporting them. So the infant's ability to bear weight while standing reflect in the picture here. Of course, we have to ask the parents to support them. Shows that their muscle strength of the lower limb is normal. Or if you want to make a quick assessment, we can actually combine gait assessment and muscle strength assessment. So gait assessment is the best to test muscle strength. So we combine two assessments into one. So while assessing the gait, we can assess the lower limb muscle strength together. And of course, in pediatric, we have to assess. We have to assess a special sign which known as Gower's sign. So how we actually do it? So we ask. Of course, we have to ask if the child can stand. So if they say yes, so we ask the child to lie supine and to stand up as quickly as possible. So if the child have a proximal weakness, they may roll onto the abdomen. As you can see, they will roll from supine position and climb up his or her legs using the strength of the upper limb. As you can see, the child use the upper limb to stand up instead of getting up normally.
Ideally, Fatin, this will be done while the patient are supine. Ideally, we will ask this while the patient are supine.
Yes.
So he will turn first to his prone and then start climbing on himself. Okay, and there is one step before this one to make sure that it is completely covered. What is the other important sign which was not present in your picture?
The important sign.
An important sign is not present in your pictures. Who can answer? This picture, the child is climbing over his lower limb. There is an added sign must be there. It is related to the leg. There is hypertrophy of the calf muscles. It is very, very important. I think in spite this one demonstrate good, but most of the baby with Duchenne muscle will get hypertrophy of the calf muscles. Okay. Okay. Continue, Fatin.
Okay. Thank you, doctor. Okay, so Gower's sign is usually seen in patients with Duchenne's muscular dystrophy. Okay, so now we're done with tone, power, and we move on to R, which is reflex. So for reflex, how we assess is similar to adults. We use tendon hammer, and we assess the reflex of the deep tendon, which is similar. For upper limb, we assess the biceps, triceps, brachioradialis. And for lower limb, we assess the knee, ankle, and don't forget Babinski. Okay, so for Babinski, actually, it is only applicable for children older than 1 year old, because for normal response, it can only be seen, the normal response flexion of big toe can only be seen for children older than 1 year old, because for children younger than 1 year old, the Babinski reflex, which we consider as positive, the fanning, is actually normal, a normal response in children younger than 1 year old. So remember, Babinski normal response can only be seen children older than 1 year old, so that we don't get false positive for younger children. Okay. So the next, however, there are special reflexes that we can see in neonates, which we call as primitive reflexes. Okay. So if you guys are familiar with playing with newborn or small babies, I'm sure you guys will be familiar with these reflexes. The first one is palmar grasp, which the response is their fingers will close and grasp when object is placed in infant's hands. I will show the picture later so that you guys can imagine it better. And next one is sucking reflex, which it causes the child to instinctively suck anything that touches the roof of their mouth. For rooting reflex, they will turn their head over towards anything that shows its cheek or mouth. For sucking and rooting reflex, it is we can clearly see during breastfeeding. Okay, stepping reflex is when soles of infants' feet touch a flat surface, they will appear to walk by placing one foot in front of the other. Okay, the last one is motor reflex. This one we already discussed, I think. We can assess motor reflex is when we support the baby's head with one hand, and then we let go and catch their head with another hand. So motor reflex is also called as startle reflex. So how it actually responds is the baby will have extension of legs and head whilst the arms jerk upwards with fingers extended. And then the arms will then brought together, hands clenched into fists, and then the infant will cry. Okay, so this is the palmar grasp reflex. This is sucking reflex, rooting reflex, stepping, and motor reflex. Okay. Now we're already done with TPR, and we already covered Babinski, clonus, and then we move on to sensation, the last one. So how we assess sensation is actually also similar to adults. In older children, we use accordingly to the dermatomes. However, in infants and young children, it is actually quite difficult for us to assess sensation because when we want to assess sensation, of course, we have to ask the patient to answer whether they can feel the touch or not. Like if we use needle to assess the pain sensation, we need to assess, can you feel it? Then they will answer yes. But however, in infant and young children, of course, they are unable to understand the command, they can even respond if they can feel it or not. Okay, so like that. Okay, so these are the dermatomes for lower limb and the upper limb. This one we also already, I'm sure you all already very familiar with the dermatomes. So that is all from me.
That's good. Just to remember you the reflexes, if you came to the reflex one, the slide for reflex, you can see here, it's just a long time ago. It is starting from 1, 2, 3, 4, 5, 6, 7, 8, from down to up. So Babinski is lumbar 5, S1, S2. Ankle is S1, S2. Knee 3, 4. Brachioradialis 5, 6. And the triceps is 7, 8. Biceps is 5 and 6. So we can just change. It is very simple. You cannot forget. Okay, it is very important. The other thing for next one for the neonatal. Yeah. Most important here for the reflexes is to, number one, to say is it present or not, and it gone already on the normal time or not, because it is available as you know, most of these reflexes must gone before the baby can sit down. So usually it disappears between 3-4 months, like that. Some difference between them. Okay, so it is very important to say is it present or not, but if it doesn't disappear like after 6 months, it means that there is some neurological abnormalities. The other important thing for neonatal reflexes is asymmetry. Asymmetry in children may guide us either if you are doing neuro, either the child has fracture clavicle, fracture humerus, or sometimes he has hemiplegia. So it is very important to detect number one, is it present or not? It disappear in the requested time or not? And the third one, what about the symmetry? The other, there is a lot of another important neonatal reflex like the tonic neck reflex, and it is very important. Okay. The other one for the sensation of the pediatric, any pediatric age, if you present your sharpener in front of him, you will be really afraid. Okay. So usually we are doing it in a very limited when the child is a bit can understand. Like we have patient up in the ward now, she has transverse myelitis. She can tell us where is the pain sensation is less like that. Can be for 10 years like that, but you must mention no need to done. I remember before the nurses tell us this baby, he was a baby. It's very strange. Whenever I am breaking, he is not like other. He will not cry at all. And really, we go through the history and we found it is a very rare disease which is congenital insensitivity to pain. And it diagnosed in the family like that. So sometimes in pediatric, there is a big difference between the adult and the pediatric, but we can overcome that. Okay. Now I need someone. I will assign someone to tell us if I asked you to do more motor examination of the lower limbs, what you will do. You can answer, or I should be the one. Of course, it is not the one who presents. Can't be. Okay, other than Fatima. So I will choose Bismillah. Where is the list? The list is here, mashallah. You are now 27. Fathul Hakim. Fathul Hakim.
Yes, doctor.
Now your colleague Fatim speak about how to examine the motor. Can you tell us what you will do?
Yeah, so for the motor examination, pediatrics. So first I will introduce myself and what I want to do for the baby, and then I will inspect. First, I will inspect the child first based on the Fatin said, sweep, bone scar, wasting, involuntary movements such as gesticulation, tremor. I will assess based on TTR ABC, which is tone, power, reflex. For the tone, I will check for spasticity or rigidity, and then I will assess the child if the child have floppy weak or floppy strong. Okay. And for the tone also, I will like to do the 180-degree examination. I will check for the scarf, like forte scarf and the others. And then for power, this for lower limb. So for power, I will can climb this side. I will can walk, I will do the gait assessment because I can assess the muscle strength and then also the gait. But if the infant, I will ask the infant if it is able to bear weight while standing. But of course, the mother has to be there to support the child. And then if there is, if the
You will be the one. You will be the one, not the mother.
okay,
Sometimes the mother said the doctor is around. If he
yeah,
fall, you
I
fail.
will,
So no. Okay.
okay, I will be the one that test the power in infant. I will
Yeah.
hold the doctor, and then if children, I would like to proceed to Gower sign. I would like to look how the infant get up. Of course, it must be done in supine position first. And if it's positive Gower sign, that might suggest the child have Duchenne muscular dystrophy. And also, if the child have Duchenne muscular dystrophy, the child have hypertrophy of the calf muscle. And then for the reflex, I would like to check for lower limb, knee, ankle, and Babinski. But for Babinski, it must be done more than 1 year old. For the ankle, like doctor said just now, ankle is to check for S1, S2. For the knee, L3 and L4. Okay. And then if the patient is a baby or infant, I would like to check for primitive reflexes, such as palmar grasp, reflex, and Moro reflex. And then for the sensation, I would like to check according to the dermatome. So I'd like to check light touch and pain assessment. The child is trying to is positive for sensation. Okay. That's all from me. And last but not least, I would like to comment for this child, the tone power reflex is normal and the sensation is normal.
Okay, so Fatin give you a clue that you must have in front of your eyes like slides telling you what is the next step. This is the thing which I need to build in your brain. When I ask it for any system, not only neurological, I must have like a series of steps which is ready to be done. And from every step, I will pick the positive findings. The positive findings, I will put it together to come to the diagnosis. Okay? Fatin, you need to add something. What is the hyperreflexia and the causes of it? Okay, and the degree of hyperreflexia is very important. Okay, there is many stages of increasing. Is it just a brisk? It is hyperreflexia, how many periods? Just to know, sometimes if you are breaking on the joint, in the tendon, there is movement. If break away from the tendon, it will also, this is another stage. If you break far away, also still very reflex. If you break the right limb, the left limb will also break. It is a very high, so you must speak about the hyperreflexia and its stages. You need to add it. The other one which we speak about the clonus also. What is the normal for clonus? Okay, what is the normal? Because most of the baby can get up to 2 to 3 bouts of clonus. So when we are going to diagnose the patient has positive clonus or not, how many beats, it is very important. The other thing, signs of ataxia, didn't speak about it at all. You said that we are going for ABC, but it looks you go for ABC and the drink only ABC. Here we must speak about the signs of ataxia. Anyone will present it after that? For ataxia or not?
Yes, doctor. There will be other presenter that present
Okay.
about ataxia later.
At least we need to just refer that we are doing ataxia, but it is included in your examination of the motor. Okay, and you must they will tell us how to do ataxia, but don't forget, because in the exam you will collect many issues together, and it is your job at that time. Okay, good. So we need to add these details which you spoke about. Second presentation.
Assalamu alaikum. Can you hear my voice? Okay. The next topic we will be presenting about cranial nerve. I'm sure that all of you know that the cranial nerve, we have 1 until 12. So this is like a revision. Okay, next. I will start with the overview of the cranial nerve and I will focus then how to perform each cranial nerve. Okay, next. We are dealing with pediatric patients, so the cranial nerve evaluation assesses the brainstem integrity, but it depends on the stage of the child's brain maturation and their ability to cooperate. So bear in mind that there will be limitation when you are doing the cranial nerve. So in the table, I have specified into which structure you will be assessing, which is in the eyes for vision and movement, face, motor and sensory, and also the bulbar, speech and swallow. So now let's go for the cranial nerve, each one. Next. To start off, we have cranial nerve 1. This is the function of your sense of smell. So smell can be assessed in verbal way as in the picture. For cooperative patient older than 2 years old, you can use materials such as coffee powder, perfume, and also vanilla. So how you to perform? In the picture, you ask the patient, close one of their nose and then ask them to sniff. So if you want to assess the left nose, you ask the patient to close the right nose and then do it vice versa. So basically, if the patient cannot smell, the patient, we can suspect there is something going on around the sinus area. Usually, the lesion can be due to head injury, rhinosinusitis. Okay. Next. For the optic nerve, this is cranial nerve 2, we will assess 4 things, which is visual acuity, visual field, and also accommodation reflex and direct and consensual light reflex. Similarly, for a patient who can see pictures, can understand your command, you can proceed with visual acuity. First, I will explain that visual acuity, you can use materials such as the Snellen chart, as you can see, and the standard visual chart, the picture of that, So how to perform? First, we establish patient wearing glass and we ask them to read the letters, but first covering their eyes, right or left. Okay, we ask them to read from the big picture to the smallest and assess their visual acuity. However, if this is not possible, you ask how many fingers you have on your hand and then you ask them to read the letters and also the picture of that letters.
What happens?
She's stuck maybe.
Even the cranial nerves are very difficult, even in presentation.
Hello? Hello?
Yes,
Hello?
Mira.
Hello.
Can you hear me?
Yes.
Yes.
I'm sorry. So where did you cannot hear me from where you cannot hear me?
If not possible to read
I
the
think
Snellen
start
chart.
with the visual standard chart.
Oh, okay. So, sorry about that. So for the cranial nerve, the optic, we will measure in 4 assessment, which is visual acuity, visual field, accommodation, and also the light reflex. So, in visual acuity, you assess patient using this material, such as Snellen chart and also standard visual chart. Bear in mind that we proceed this method if the patient can understand our commands. So how we do it? We do it by establishing first the patient wearing glasses or not, and we ask the patient to cover their right eye or left eye and read the letters or the picture from the biggest until the smallest. Okay, so if this is not possible, we ask how many fingers you are showing, your hand movement, and also distinguish light from dark. So how about babies that cannot understand your command? So you can still assess visual acuity by seeing their eyes movement, distinguishing light from dark, and they can see your faces. So in newborn, the visual acuity is 20/200, and in 6-month infants is 20/20. Okay, next. For the next assessment is visual field. All right. So in this visual field, similar, there is 2 picture. Next. Okay, there will be 2 picture for those who can understand command and those younger children. So I will explain first those who can understand command, such as more than 2 years old. So what you do is you confront the patient by asking the patient to sit opposite you and ask them to focus onto your eyes or nose. So when you're asking that, you will then move your finger from the corner slowly to the center and tell the patient, say yes when you see any fingers wriggling. Repeat this step from all corners of the eyes. So how about younger children? You cannot do this. So what you can do is you need to play with them in terms of attract the child's attention, and then you move an object from behind towards inside towards the baby. So if the head is moving towards the side of the target, this indicates an intact peripheral field of vision. Okay. Next, for accommodation reflex, you will be testing on the pupillary convergence and constriction. So you ask the patient, focus on your finger, and then you move towards the patient nose. So if in normal situation, the patient eye will look cross-eye and the pupil should constrict. For the direct and consensual light reflex, you are testing using a flashlight. As you can see, when you shine a light in one of the eye, supposedly both of your right and left constrict. This is called consensual light reflex. However, if the patient have an abnormality in one of the eye, there will be inappropriate dilatation of your pupil. So commonly, this is what we call afferent pupillary defect, which is Marcus gun pupil. All right, finish with that cranial nerve. Next. Now, the important part of cranial nerve 3, 4, and 6, they will assess your ocular muscles. So you can see in the picture, I have stated there are various muscles that support the eye movement. So the method is you ask the patient, do not move the head, and follow your finger as you trace the letter H and ask if they see double vision. So when you are assessing them, the eyes must move in all direction in coordinated and symmetrical function. But in baby neonates, you cannot assess this. The baby cannot trace your H. So how would you do? You will attract the patient once again with colorful toy to capture the child's attention. Now you can see the movement of the extraocular muscles. Okay. Mm-hmm. Next. For the cranial nerve 5, trigeminal, you are assessing sensory and motor. So in the picture, in the sensory part, you test first the sensation using a soft cotton wool at 3 main areas, which is the forehead, cheeks, and chin, because trigeminal nerve have branches. And don't forget to check the corneal reflex. It will be slightly uncomfortable for the child, but try to make it. For the motor, you are asked to clench the patient's teeth and palpate over the cheek and temple. So you are assessing the masseter and temporalis muscle. Okay, next. For the facial nerve, you are assessing the motor facial muscle and also the taste sensation to anterior two-thirds of the tongue. So focus on the picture I have shown to you. There are 1, 2, 3, 4 pictures. The first one, ask the patient to raise the eyebrow. So you are assessing the frontalis muscle if there is wrinkling. Okay, next, you ask the patient to close their eyes and shut tightly while you are trying to open it. So you are assessing orbicularis oculi and simply ask the patient to smile because you want to assess any palsy, facial nerve palsy. So you see any obliteration of the nasolabial fold and look for deviation of the angle of the mouth. And lastly, ask the patient to blow air, assessing the buccinator muscle. For child who neonates, you can assess them uh, by observation during resting, crying, and also blinking. This take time. So, okay, and sensory, test for taste in the anterior two-third of the tongue. Okay. Moving on to the cranial nerve 8, which serve your function of hearing. So if there is a lesion to this hearing, it can cause deafness, tinnitus, and also vertigo. So it differs in the age group. Example, in neonates, when the patient will blink in response when there is a loud sound. For 4 months old, they can hear sound by turning the head and eyes to localize where is the sound. For verbal child, simply you whisper to them and ask them what you are whispering. Okay. Next. All right, we are ending. For the cranial nerve 9 and 10, you will assess the levator palati, which is the muscle of your soft palate, and also the recurrent laryngeal nerve. Basically, you will ask the patient to open the mouth and see the uvula, as in the picture. Is it deviated or not? And ask the patient to say ah. Okay. For the vagus nerve, you are assessing the recurrent laryngeal nerve. So if there is an abnormal sound, for example, stridor or hoarseness, you can suspect there is an upper airway obstruction. So this you can assess also by doing gag reflex. So gag reflex, what you do is you test by touching the back of the throat by a tongue depressor. So if there is no gag reflex, the patient might be having lesion to this cranial nerve. Next. All right, for the cranial nerve 11, which is the accessory nerve, you are checking the muscle of the head, the neck, and also the shoulder. So focus on the picture. The first picture, you are checking the sternomastoid muscle. So you ask the patient to turn the head against your resistance. And the second picture is ask the patient to shrug the shoulder in terms of assessing trapezius muscle. Okay, next. For the hypoglossal nerve, you are checking the muscle of the tongue. So simply ask the patient to protrude the tongue. If there is a lesion, the tongue will deviate towards the weak side. For example, in patients who have lesion at the anterior horn cell, example is the spinal muscular atrophy or the poliomyelitis, the patient can have atrophy and fasciculation of the tongue. So this is my last slide. Next. So this is the summary of cranial nerve from 1 until 12 and the function and its function. Is there any question you would like to ask?
Okay. So now we already knows how to from Amira how to examine the 12 cranial nerves. So anyone need to raise his hand and do it, or should I assign?
I have a question.
Yes.
Does we do this cranial nerve examination to children who are able to comply? What about children who less like want
Yeah.
to
So
feel?
I will assign to one, the one who is compliant and the one who is not compliant with this. Okay. You must do. Your job is to do. So who can tell us if the patient is compliant? How can we examine the cranial nerve? Ali Gamon?
Yes.
Yes.
So,
Tell us,
all right.
Ali, if the patient is compliant with you, like he is 8 or 10 years old, how can you examine the cranial nerves? Rapidly, tell us the steps.
So if you want to test all 12, then I will start with the first one, olfactory. So I will test the sense of smell by each nose, left and right. If there is if you can't smell, then might be a sign of any rhinosinusitis or any other abnormalities. Then the second I'll test is for the eye, the optic. Optic, there are 4 that I have to test: visual acuity, the visual field, accommodation reflex, and also direct and consensual light reflex. All right. So the visual acuity, I will at 10 years old, I will just give the Snellen chart. Visual field, I will ask the child to follow the finger it can able to see while fixed to my nose. Accommodation reflex, I will test for the reflex, accommodation reflex, the pupillary convergence and constriction, and then also the reflex. Then the next step is the motor, the eye motor, oculomotor trochlear subudation. So I will try to see if the eye muscle is able to move normally to test the third, fourth, and sixth cranial nerve. Then the next is the fifth cranial nerve, trigeminal. So there are 2 I can test on the fifth one, which is the sensory and motor. So there are three areas: the ophthalmic, maxillary, and the mandibular. And then next is the seven facial nerve, facial. So I also same I can test also the motor and sensory. So for motor, and then the eighth is the vestibulocochlear. Here I will test the main function is to test the hearing. And otherwise, if there's a linear lesion, might be deafness, tinnitus, or vertigo. So I will try to whisper a word to the child if he can hear one left, then to the right ear. The ninth and also the 9, I'll test the glossopharyngeal, which is by asking the patient to say if any deviation of the uvula, and also then I'll test the vagus if there is any to check the recurrent laryngeal nerve, if any hoarseness or stridor. Otherwise, if there's any abnormality, then it might show any breathy or weak, unable to handle secretion. Then the 11 is the accessory, which we want to test the muscle of the head, the neck, and the shoulder, which more specifically the trapezius and the sternomastoid. And then the last cranial nerve, the 12, is the hypoglossal, where we test the muscle of the tongue by protruding and checking if any deviation. And we also can observe the tongue if it's atrophied or any fasciculation. I think that's all.
Okay, so now Amira did the same. She put in front of us the 12 cranial nerves. In your practice after that, you need, as if you are looking to it in front of you. Okay, it is very, very important, and to know what to do. So we need two things now from Amira. Number one, you didn't touch the squint and nystagmus. You need one. Okay. Yes. Type general simplification of type of we can see that iso, exo, okay, divergent or convergent. Okay, this is number one. Also for nystagmus, I know that it is a part of incoordination or ataxia, but it is very important. As if you just find the nystagmus, you must ask him, what's your name? Just to go to his voice, this attack is or not. Okay, you speak oculomotor. Yes, here I need just to do to one only for squints and nystagmus.
Okay, doctor.
The other thing also is the 7 cranial nerves. It need to be. I know that I need to do 7 cranial nerve policy, because many of you, even in the exam, they are not able to define which side. They can say, yes, there is 7 cranial nerve. So we just check. Is it bilateral? No, doctor, it is unilateral. So which side is right, left, right, and let us choose. Okay, so it is very important to comment, to add some point. I know that the picture is there, but the 7th cranial nerve is the one of most common, even you can see it as Bell's palsy occurred to secondary to just common cold or otitis media like that. The last one, which you need to add, is the bulbar and pseudobulbar palsy. Because in pediatric we have a very common disease, which is the pseudobulbar, known as lower cranial nerves. The bulb is the brainstem, the bulb area, which means the lower cranial nerves, which is 9, 10, and 12. Together they be mixed, especially in case of cerebral palsy and other insult to the brain. So we need to add sequent, nystagmus, 7th cranial nerve, and the pseudobulbar and the bulbar palsy.
Noted, doctor.
Now the remaining one, I think we can ask someone other than you to add it for you. The one who he doesn't share today, he can make just a simple presentation of it. Will be 5 slides added to your cranial nerve, one for sequent, one for nystagmus, one for the 7th cranial nerve, simply, and the bulbar and the pseudobulbar. And the last one, the last slide will be how to examine the small baby like infant and newborn or uncompliant child or panic child. How can we comment on the cranial nerve? Because in our life we are not doing with all or none rule. We cannot do that for them. If I cannot examine the patient completely, I will do my best. So you will go by, what is my advice for that is just go through organ. I mean, we'll go for general look, okay, and then we'll go for the eye. The eye will inform me about 2, 3, 4, 6, yes? So by concentrating on the eye, is there any abnormality? Is there any nystagmus? Is there any squint? Is there any other findings? Okay. So I am able now to discuss the 4 cranial nerves. Of course, number 1, usually it is very difficult. So at least now I finished about 6 cranial nerves because number 5, which is the sensation, is not applicable. Yes? Then when I come to the 7 cranial nerve, it is so easy because it is the nerve of asymmetry. So I'll just comment about, is there any nasolabial faults? Is not symmetrical? Is there facial asymmetry? What happens when the child is crying? Is there any shifting? And this shifting, is it the normal or abnormal side? Okay. And then what about his eyes? He can close both and open both simply, or is not like that. There is one eye which is not closed, still loose, is not tightly closed. The other one, so it is very important. Through the eye, it will give you also clue for the 7th cranial nerves. Can you hear me?
Yes, doctor. Yes, doctor.
So we speak about the eyes. Okay, we speak about the 7th cranial nerve alone. How can we diagnose it? Okay, then we go for the hearing, which we can do just like a hearing distraction test or whatever, checking for hearing, it will be okay. And then for the lower cranial nerves, which can be also simply done if we are concentrating, okay? If the patient is crying, that's why we must be opportunistic. If he's crying, what looks his voice? I will go and try to see his tongue. Is it deviated? Is it atrophied? What about his uvula? All this can give me the same live sequence. Did I answer the question of your colleague now?
Yes, doctor.
I need to comment that in the slides, okay? And remember that the good penetration is a good opportunistic for the examination. You must start by the point where the patient is in. You cannot ask the child to come with me for 1 to 12 until he is eldest enough to understand and cooperate. Okay? But like I told you now, it is very small baby. I found him crying. Why not to jump into the mouth, try to tongue and uvula and anything? If you start to cry, why not commenting about the symmetry and the nasolabial fold and the eye closure? He's looking at me and afraid. Let me look at his and go to the right and go to the left, go up and go down as if I'm doing complete test for eye movement and nystagmus and sequence. Is it so simple? But you must insist to complete your examination. So you get complete picture of the situation. So you are managing on ilm, not in jahl. Okay? So that is the correction for the first presenter and the second presenter. It needs to be completed. Do you have any questions? Dr. Alawi, welcome.
Yes.
Come open. We have now the presented nice presentation for the motor examination. And the comment about the reflex and tone power and reflexes with ABC, which is ataxia, and B is Babinski and Skonas, and we give them some points to be completed, which is The first presenter, what you will complete.
First presenter just now.
Typing
Yes, yes, doctor.
what you will complete in your presentation.
The causes of hyperreflexia, and then the grade,
A degree. Yeah,
grade
degree.
staging of hyperreflexia,
Okay.
and then how many bits we consider as clonus.
Okay. What else?
What else?
To include the ataxia in your examination. Even
Oh.
your colleague is going to present it. It is a part of the examination. For the second one, they spoke about the cranial nerves, Dr. Alawi. They did a good presentation, but we asked to add some points, which is
Regarding the squint, nystagmus,
Yes.
how to diagnose the seventh cranial nerve, the eighth cranial nerve, and also the lower cranial nerve if the patient is crying.
Okay, and pseudobulbar palsy, which is the most common in children. And the last one, how to examine the cranial nerves if the child is not cooperative. Okay, it is very, very important as we speak about. Now, Dr. Alawi will supervise you for the remaining parts. Okay.
What's next? What topic's next?
Coordination.
Okay.
Hello. Okay. So next we move on to the topic of coordination. Okay. Okay, so what is coordination? Coordination is it can define ability to perform the smooth, accurate, and control movement. Basically, for coordination, it is controlled by cerebellum, because in cerebellum it has multiple connection to sensory pathway, brainstem, thalamus, and cerebral cortex. However, in order to perform coordination, we also need intact motor, sensation, and vestibular, aside from having normal cerebellum function. Next. Okay, so is disturbance in smooth performance of voluntary motor action, or we can simplify ataxia is the lack of coordination of the movement that usually due to cerebral lesion. Other causes of ataxia can be due to sensory disorder and upper motor neural lesion. However, in this presentation, I will explain on cerebral examination only, as it is the most common cause of ataxia. Next. Okay, in order to perform cerebral examination, we need to ensure that the patient has limb power at least 3 out of 4, because they need to move the limbs against gravity to perform coordination maneuver. Okay, next. Okay, firstly, we start with general inspection first to look the clinical sign that can suggestive of underlying pathology on the patient. Okay, firstly, we look at the patient gate as the patient enter to the room. Because in cerebral pathology the patient have broad base gait is part of the screening. Okay, also we need to look at the scar, especially at the back of the head, to indicate that there may be previous neurosurgery. And also not to forget to look for equipments on or around the patient that may provide the useful insight into current clinical status of the patient. For example, if there is walking aid, it might indicate that the patient may has imbalance during walking. Also, the hearing aid that can indicate hearing loss, and also prescription to indicate the recent medication that the patient need associated with underlying cerebral pathology. Okay, next. Okay, okay. Okay, next. Posture. Posture. Okay. Sorry. Okay, so after patient has sit, we need to assess for the posture. Which we want to see, is there any truncal ataxia that may indicate cerebellum dysfunction. Which we ask the patient to fold the arms and sit upright. Um, so in truncal ataxia, the patient will have the sway of head or trunk while try to sit, because the patient unable to support their trunk independently. Mm. However, for young children, we can watch them to sit or walk, as they does not cannot understand to the our command. Next. Okay. After have assessing the posture, we go to the face. Next. Okay, so for the face, we assess the eyes, because we want to lead any presence of the nystagmus. So to assess the nystagmus is similar with we assessing the extraocular muscle examination in cranial nerve 3, 4, 6. Okay, which we ask the patient to look straight to us and keep their head while following examiner's finger, and then we move the finger in H pattern while the examiner observe any nystagmus. So the causes of nystagmus other than cerebral disease can be due to severe refractive error, vestibular disease, and congenital nystagmus. Yes. Okay, so for the speech, we can ask the child any question or ask him to read. However, in older children, we can ask him to say hippopotamus or West Register Street, as they able to follow our command. So in speech, we will look the staccato speech or scanny dysarthrasia. Okay, next. Okay, after we have finished with our face, we go to upper limb. Okay, next. Okay, in upper limb, we want to assess, is there any pronator drift, which we ask the patient to hold their arms straight, and then they turn their palms upward with closing the eyes, and then we observe for any evidence of drifting. Okay, as you can see on the picture, on the A is normal. However, for the B, there is pronator drift at left side. So that if there is positive or pronator drift, it can indicate upper motor neuron weakness, cerebral disease, or loss of proprioception. Next. Okay. Next we assess the tone. For the tone, the assessing is similar. We will assess upper limb examination of the tone. So in assessing the tone, we need to support the patient elbow, and we want to see, is there any hypotonia. Next. Okay, next for finger nose test. which finger nose test, we ask the patient to touch their nose with index finger and touch the examiner forefinger. However, we must remember that the patient elbow and shoulder must be near at fully extend, because we want to avoid the patient having compensating of their arm if the patient is tremor. Then we repeat the test with other side. So in finger nose test, we want to see is there any intention tremor, which tremor that will increase as the target is approached to our fingers, or any past pointing that the patient overshoot the target. However, for the infant or young children, we can assess the finger nose test by exchange the toys with them. Next. Okay. We also need to look is there any dysdiadochokinesis, which we want to test rapid alternative movement. We ask the patient to turn their hand over backwards and forward on the other hand as quickly as smoothly and as possible. Because if there is any dysdiadochokinesis, they will be slow and clumsy. So, the other causes of diastachokinesis can be due to internal capsule infarction or Parkinson disease if occur in elderly. Okay, next. Okay, next for rebound phenomenon. Rebound phenomenon, we ask the patient to lift the arm rapidly from side and the stop. Because if there is delay in stopping, there is cerebral disease. So, why rebound phenomena occur? Because there is coordination of antagonist and agonist action of the mass of the arm. So, it causes the patient unable to stop the arms. Next. Okay. Okay. After feeding with upper limb, next we access to lower limbs. Next. Okay, so first we assess the tone. Okay, so to assess the tone is similar with we test for tone up lower limb examination, which we want to see is there any hypotonia. Next. Okay, so for the reflex, for the reflex, we want to see is there any pendular nidget. Okay, pendular nidget is less brisk and slow. The fall and rise of the leg after being tapping by tender hammer. So it is bouncing when the patient limb left hanging in the air. Next. Okay. Other than that, we want to look. We will assess the heel shin test. With in heel shin test, we ask the patient to put the opposite heel, on the shin, and then go down to the ankle slowly. After that, slide the shin up, which we need to repeat 3 cycle for each side of the leg. Next, we test to the other leg. So it abnormal, the foot we wander side to side and overshoot. Next. Okay. For the foot tapping test, also we can assess coordination, which we ask the patient to tap the sole of foot quickly on examiner hand, because we want to see is there any slow and irregularity of the rhythms. So it can be indicate of cerebellar or corticospinal dysfunction. Next. Okay, finally, we end cerebral examination with gait. Next. Okay, so before assessing the gait, we can assess rhombus test. However, for the rhombus test, it's mainly to assess proprioception and vestibular function. So we get the child to stand up and maintain position with feet close together, and then ask them to close the eye. So if the finding, the child we have unsteady with eye closed, that can indicate sensory ataxia, which means that the patient might have ataxia that be due to non-cerebellar dysfunction. Next. Okay, for the gait, we ask the patient to walk at the end examination of the room. And then turn and walk back. Why the examiners observe their gait? So in cerebellar dysfunction, the patient has broad base gait or wide base gait because the patient have unsteady during walking. Mm. Okay. So okay, so also to confirm that the children really have ataxia, we can ask the children to walk with his to their toes or no extend the gait, because in the tender gait, the patient will show more unsteadiness. Yes. Okay, so the is summary for findings in cerebellar dysfunction. Mm. Next. Yes, and also for this slide, it show the causes of cerebellar lesion. Mm. Next. Okay, so you can read it by on yourself. Okay, that's all.
Okay, that's good. I think it's very comprehensive. Uh, okay. So first at the inspection, let's go through the slides. Let's go through the slides from the beginning. Okay. Okay, general inspection kan. Uh, okay, definitely you need to look at the gate. Okay. Ideally you don't want to burden the patient. Okay. It depends on what is the original position of the patient. If the patient is lying down when you meet the patient, then you start your examination from lying down. But if the patient already set up, then you start with sitting, and then proceed with your gait lah. Uh, you don't I mean you should not burden the patient by, for example, patient is sitting up, you ask them to lie down and then stand up and then lie down back and then walk. So ideally it depends on the position of the patient lah. And again, pediatric, you have to be opportunistic, like Dr. Musad said. For instance, if the child is very incooperative or very fretful, then you have sometimes if you can approach the child just merely by inspection, it can give you ideas. It can give you ideas. For example, maybe you can ask the parents to help ask the child to stand, and then you can observe for nystagmus using toys kan. Use toys, use toys to force the child to look at distant. To force the child to strain the eye. For example, bring the toys in front until 180 degrees so that the eye will actually move using the toys. Following the toys. And then you can observe for nystagmus. For the scars, okay, it's very difficult actually sometimes to see the base of skull near surgery. Okay? And sometimes patient may have, for example, a problem at the pituitary area, so they have like transsphenoidal surgery that you may miss. Okay, you may miss lah kalau the surgery is actually, if the surgery approach from your transsphenoidal. So the other things that you can see and you can actually observe for is the presence of VP shunt. Okay, VP shunt. If try to look for VP shunt. Okay, sometimes you may miss the surgical scar, especially kalau the at base of skull. But you should not miss the VP shunt. Okay, what else? And then the posture of the patient is very important. Okay, If the patient sit up with look imbalanced, you have to comment on that. If the patient looks imbalanced, kan, just by merely observation, for example, especially those patient with vermis punya pathology, vermis tumor at the vermis or extensive cerebellar tumor, they will have abnormal movements such as titubation. You know, the head was like nodding. They will have titubation. This is what you call titubation. And then the the direction of the ataxia can actually give you clues where is the pathology. For example, if the child is actually titubating, like rocking forward and backward, so you know the problem is actually at the vermis. Okay, but if the patient fall to right side, then you know the pathology is at where's the pathology? Kalau dia fall towards right side,
Lateral cerebral.
yes, at which cerebellar hemisphere, right ke left? Kalau fall to right side. It's actually right side lah. Okay, cerebellar dia is different than your cerebrum. Cortex is different than your cortex because your cortex is they could sit dekat medulla kan. But cerebellar lesion, you get ipsilateral lah. Okay, usually if the child fall towards right side, then chances are the lesion is actually at the right side. So do left side lah, vice versa. Okay, that is for inspection. And then let's look at the next. Okay, equipment is very important, definitely equipment. And sometimes you have to understand if the child wearing glasses, you have to comment on that lah. For example, sometimes you see young children with very thick glass kan, then it might, so possible the problem is actually peripheral rather than central, because peripheral can also cause nystagmus, can also cause sometimes a bit of ataxia lah. Okay, next. Okay, posture kan, posture. Okay, truncal ataxia. Okay, okay. For example, if you start your examination from lying down and then you ask patient to sit up, okay, how do you differentiate whether, I mean, you have to differentiate whether this is actually because of weakness rather than ataxia. Because when sometimes some people with motor problem kan, either lower or upper motor, for example, spinal problem, they can have weakness of the truncal muscle. Okay, truncal muscle. So they may not be able, truncal or proximal muscle, so they may not be able to actually sit up. Okay, because of the weakness rather than because of ataxia lah. Definitely in patient with cerebellum, they also got weakness, tapi the weakness is actually because of the cerebellum. It's not actually weakness, muscular weakness. Okay, and then next. Okay, eye nystagmus. Okay, nystagmus. Sometimes in very severe disease, you can see obvious nystagmus at rest. But most of the time, you have to force the eye, force the ocular muscle to the extreme. So at the end, for lateral or top, top H lah, the H direction kan. At the end, baru you nampak nystagmus. And then sometimes the type of nystagmus can actually give you clue what is the problem kan. If you got the usually in cerebellum, you've mentioned rhythmic regular oscillation of the eyes kan. In cerebellar, you usually get it can be both lah, vertical or horizontal nystagmus. But if I'm not mistaken, it's horizontal. You should check on this lah. What sort of nystagmus patient will presented with in cerebellar lesion, because definitely in vestibular lesion pun you akan dapat nystagmus. In cranial nerve problem pun you can get nystagmus. Okay, okay, next. Okay, pronator drift mana? Did I miss it? Yes, pronator drift kan. Okay, so why do you ask patient to close eye in pronator drift?
For proprioception.
You're not assessing. Of course, if you're assessing proprioception, you also need to close the eye. Kenapa? When you're assessing, because when you, for example, pronator drift can be caused by anything. It can be caused a lot of things. Upper motor neuron disease, cerebral problem, your sensory problem, peripheral nerves. Actually can cause pronator drift lah, your proprioception semua kan. So that's why you ask them to close the eye, because if you let patient to open the eye will actually give information to your brain and they can compensate. Okay, you may miss pronator drift if you open the eye. Okay, you want to diminish the effect of the vision lah, the information from the eye, so that you can actually assessing specifically on the cerebellar or proprioception. And in pronator drift, how will the upper limb drift? What direction the upper limb will drift to when they have cerebellar lesion? At what direction? To which direction? Sorry, for cerebellar lesion. Because you mentioned upper motor neuron weakness can cause pronator drift. If you've got upper motor neuron weakness, you can cause. If you've got lower motor or you've got spinal problem, loss of proprioception, you can also get pronator drift. So how to differentiate them? Okay, I think you need to look for this. I mean, how to differentiate. What is the difference between pronator drift finding in cerebellar, in proprioception, and also in upper motor neuron weakness? Okay. Especially the proximal lah. You don't get upper motor neuron weakness. If you get weakness distally, okay, distal muscle weakness, you won't get pronator drift. You get pronator drift if you got proximal muscle weakness. For example, proximal muscle is supplied by your what? T what? Your shoulder. It's usually higher up lah. Okay, higher up. Your distal is T1 kan? T1, C8, C7. Okay, so if you got lesion at the level of C4, for example, kan? So you can get proximal, mainly proximal lah, proximal weakness. Tapi if you got like more distally, your proximal, for example, you got transverse myelitis at level of C8 or C7, your proximal usually will be preserved, so you won't get pronator drift. Okay? Because pronator drift is actually just weakness. Because you feel tired kan, macam lengur of your proximal muscle, then you get the pronator drift lah. Okay, what else? Okay, next. Tone. Again, tone is non-specific. Okay, you get hypotonia in also lower motor. Okay, next. Finger nose test. This one I think I like the way you've mentioned that use toys kan untuk swapping toys in pediatric, and that's how we do it lah in children. Okay, again. This diadokinesis, okay lah. You have to demonstrate this. In pediatric, you may have to demonstrate this. Okay, rather than you, because it's much easier to demonstrate rather than you explain. This is difficult for them to do this. Okay, next. Rebound phenomenon. Okay, this is quite easy to do now. They've got delay in stopping. And remember, in patient with basal ganglia problem, for example, like Parkinson, they also got problem with it's not we don't call it rebound phenomenon. We call it the bradykinesia can actually cause they will unable to actually stop or initiate movement abruptly because of the basal ganglia problem, not extrapyramidal problem. So they will have also delay in stopping. Okay? But cerebral lesion is more, we call rebound phenomenon in cerebral lesion now. We don't call it rebound phenomenon in Parkinson, but again you can have similar findings. Okay, next. And don't surprise, actually I've met a child with Parkinson back in Kelantan who respond well with metadopa lah. Okay, tone is okay lah, it's okay. Tone hypotonia. And previously during the your motor punya assessment kan, do you know how to assess tone? How do you score tone? Okay, there's a scoring lah for tone kan. Okay, you can use the Ashworth, modified Ashworth kan, modified Ashworth score. Okay, but usually in non-neurologists, you can just say it's hyper or hypo or normal tone. reflex. Again, it's pendulum tau. It's pendulum. Sometimes you may confuse between pendulum cerebellum reflex and also hyperthyroid reflex. How you differentiate between hyperthyroid and also cerebellum reflex? Because in hyperthyroid problems, especially grave, you also got problem with the reflex. So how you differentiate between the two? Understand? Understand? You present the thing.
Yes.
How do you differentiate between hyperthyroid and also cerebellum reflex?
Betul.
Okay, so you baca lah. You baca on that. It's quite interesting though. So read on that. Later you can share with your group now. Share with me and also Dr. Musarga. Okay, okay, next. Okay, Hilshin test, it is boring. Okay, next. Foot tapping. Okay. Again, this is not specific lah. Some of these assessment are not very specific for cerebral. In fact, most of the assessment not very specific, like tone, power, reflex are not that specific, and it's sometimes very difficult to listen. The next, gate. Okay, gate. Okay, Romberg test. Definitely one before you start your gate, do Romberg test first. Okay, don't do gate and then lie down, examine, and then you do Romberg. Don't cause like trouble to patient. Okay, good. Again, Romberg test. That's why you ask them to close their eye, so that the eye will not compensate for the defect in the cerebella or in the proprioception. Okay, next. Okay, this is a gate. Okay, again, this is very good. So remember, it's a broad-based gate. It's a gate similar to those babies who just learning to walk. Okay. Okay, next. Okay, tandem. Okay, tandem gate. Okay, I'm not sure you call it tandem gate. I think you call it tandem walk. This is an assessment where you actually force patient. The instruction is okay. Walk along a line. Okay, this is what we call a tandem gate. Walk on a straight line. So walk along a straight line. Okay, next. So again, the direction of the fall will determine the lesion. Okay, kalau for patient fall to the right side, the lesion is at the right side. Fall towards the front, I mean the titubation to the front or the fall forward or backward, usually it's vermis lah. Okay, so that's all good. So very good summary. Okay, etiology again, cerebral lesion, okay, that's all. Maybe mainly is actually either due to structural ataupun space occupying lesion. Okay. Good. I think that's all. So let me pass to Dr. Masad. Right.
I have question on about the speech just now.
Oh
The
yes.
presenter give example of the word be said, but it is in English. How about in Malay? What we ask the patient to say?
Okay. Problem with Malay kan? Problem with Malay. Some people they say perlembagaan. For example, perlembagaan. Or can't remember. Kanak-kanak. I remember. I think it's perlembagaan. You need to find a word that is staccato in nature. You know, staccato is like staggering word. So hippopotamus. So in bahasa Melayu, I can if nak bahasa perlembagaan macam some people use. But the problem is it's not validated and it's not it's something that is not reliable because it has not been tested. The use and it's not specific nor sensitive. But the word like hippopotamus or constitutional, these are words that has been validated to be used to assess your cerebellum. So you should use the word lah yang given even though it's in English. Because hippopotamus orang Melayu pun boleh sebut. Okay. For Malay word, as long as the principle is the word has to be staccato in nature. Okay, staggered. Kalau bahasa Melayu, I can think of any word. Anyone can suggest any word that is staccato, like staccato in nature lah. Maybe like momo. Maybe things like that. But L is not that difficult. It's usually words that is abrupt. Staccato lah, staccato, hippopotamus, British constitutional. That's the main word. Okay. Any other questions?
Thank you, Doctor.
Okay. I'll pass to Dr. Masalah.
Just we need to add some points because your general observation is not about the general look of the patient. He looks dysmorphic or not. He looks special or not. If the child still have bumpers, still have like that, rolling saliva, all this will give you clue like cerebral palsy, like even the child has a chicken pox, because this is one of the most common causes of ataxia in children. And then you must comment about his growth and the development and his speech and his head, because hydrocephalus or microcephaly is one of the important neurological. So you must comment. I know that you are studying all medicine, but for us, you must comment. Even this hydrocephalus can come to you in the exam as a separate case, and you must be able to comment for that, okay? So try to concentrate in the pediatric issue. Now the remaining is the GATE exam. Okay, you can go for the GATE exam with Dr. Ali.
I'm sorry, doctor. Some of us will have class at 12 p.m.
Yes, inshallah, 15 minutes we'll finish. Try to finish your GATE. Galan.
Okay, so Bismillahirrahmanirrahim. So I will be presenting about GATE assessment. So next slide. So this is my outline. Next. So when we're talking about GATE, so we need to know about normal GATE first. So we know that normal GATE usually consists of smooth coordination of the pelvis, hip, knees, ankle, as well as the foot. So you know that normal GATE cycle, we have two phases. We have stance phase and swing phase. So you can look at the picture. Each phase has their own steps, level. So we need to know that this normal GATE usually only can be seen in adult GATE. So in children, usually they those who age 6-year-old can have this type of adult GATE. But what about a younger age group? So next slides. So that's why we need to go back and look their capability of the gross motor. It's different according to the age group. As you can see, for the 12 months age, so they can walk with one hand held, and for the 2.5 years, they can jump with 2 feet together. For 3 years old, they can walk but on tiptoe. For 4 years old, they can run, they can hop. For 5 years old, they can walk on narrow line. Next slides. So for the GATE assessment, so usually what you need to do first, you observe their walking. So it's according to their age. If they are 4 years old, you can ask for them to stand on one leg for 5 seconds or hop. If they are 5 years old, you can ask them to walk straight line about 20 steps. And if they are 7 years old, you can do a tandem test for them. Next. So I will go for the abnormal gaits in pediatrics. So there are a few. So first one is the ataxic gait, or also known as broad-based gait. So this gait is characterized by clumsy, staggering, as well as a wide-based gait. So as Dr. mentioned earlier, it's normal in toddler to have this type of gait because they are start learning to walk. And usually this type of gait is a sign of lower limb weakness as well as the cerebellar disorder. As mentioned, the patient can have a vermis, problem they can have a vermis problem, and usually this patient who have ataxic gait, they are swaggering back and forth even when they are standing. Next is the narrow gait, so also known as scissoring gait. Usually this gait is a term to describe when the patient has excessive rigidity as well as excessive knee adduction. So you can see that they have like their knee are rubbing each other, and they have like cross in manner. So they have a scissor like shape. So usually they have tiptoe walking. You can see this type of gait in patients who have corticospinal tract dysfunction, or you can see in usually in cerebral palsy patient. Next is the spastic gait. So as the name suggests, usually they have stiffness, and what this stiffness cause they to drag their foot, and you can see at their foot, it is invert. There is inversion of the foot, and you can see this in diplegic or quadriplegic cerebral palsy. Next slide. Another abnormal gait that you can see is myopathic gait. So this myopathic gait is also known as waddling gait. It is a sign of proximal muscle weakness. So what happened in myopathic gait is that usually when they start to walk on the weight bearing leg, so the other side, the other side of the hip will fall, on the contralateral side will fall, and this is due to the muscle weakness of the hip adductor. So when they have a fall on the contralateral side, we know that this is a Trendelenburg sign. So for this patient, they try to compensate because due to this condition, they tend to fall. So what they do is that they try to compensate with their shoulder on the weight bearing side in order to prevent them from falling. So you can see this type of gait in patients who have proximal muscle weakness, such as in Duchenne muscular dystrophy. Next is for the last, this is a foot drop or high steppage gait. Usually, this gait is occur in the patient who have distal disorder, lower extremity disorder, such as usually due to peripheral nerve lesion. So what happens is that they usually have inability to dorsiflex their foot. So when they have weakness to dorsiflex, so they don't have heel strut. So when they don't have the heel strike, so they can't have a normal gait. So what happens is that they try in order to clear their foot, so they will try to bring up their knee height in order to clear the foot. So you can see this usually in uh, those patients who have distal muscle weakness, such as in hereditary motor sensory neuropathy, or also known as Charcot-Marie-Tooth. We also can see this type of gait in the polio patient. So I provide a video, but you can see it later. So next assessment, to complete neurological assessment, is that you need to check also the spinal cord. So we know that the spinal cord ends in adult at the level of the L1 and infant at the level of L3. So what you need to do is that you need to examine the base of the spine. So you need to check for any skin lesions such as birthmarks or hair, because you want to look for any spinal dysraphism, meaning that you want to know is there any uh, congenital anomalies of the spine, is the because it can suggest this patient might have spina bifida, or this patient might have a tethered cord. So I think that's all. So this is the link. So you can all the gait demonstration can be seen in this link.
Okay, that's very good. Very comprehensive. Okay, can we go from the first slide? Okay, this one. Okay, good. Okay, stance and swing face. Okay, remember, when we look at gait, we not only look at the lower limb, we look at the upper limb as well. Okay, when you assess the gait, the upper limb can give you a lot of clue. Okay, a lot of clue, especially um, because sometimes patient compensate. For example, in balance, in patient with ataxia, they use their hand to compensate. So patient with ataxia, sometimes they open up. I mean, they abduct their hand. And patient, for example, patient in CP and with CP, hemiplegic CP especially. Okay, if they are forced, I mean, if they are struggling to walk, for example, when you ask them to do tandem walk, or you ask them to do like heel apa tu heel toe or fork test, sometimes by looking at the hand, it can give you clues. Okay, because they will have like abnormal posture of the hand when they are compensating. Okay, so look at the hand as well. That's why the examiner, you have to stand away from the patient, from away lah. You don't follow patient when you assessing gait. You stand at the end of the room, ask patient to walk. However, you need someone else to actually assist patient just in case patient fall. Okay, so look at both upper limb and lower limb. Next. Okay, this is very good. This is very good. You have to assess patient according to their developmental ability. Okay, definitely you cannot ask patient to walk on straight line. 4 years old definitely cannot walk on straight line. 3 years old definitely cannot walk on straight line. Okay, 4-year-old they can. Even 5-year-old you cannot ask them to tiptoe. 4-year-old cannot ask them to tiptoe. They may not be able to do it. Okay, but usually 5 years old they should be able to do it. Okay, next. See, this is very good. This is very good. Okay, you have to remember this. Okay, next. Okay, ataxic, mentioned just now, narrow gait scissoring. This is especially in patient with diplegic lah, especially spastic. Okay, good. Myopathic gait. Okay, myopathic, you mentioned associated with Trendelenburg. If patient positive with Trendelenburg, okay, in orthopedic you learn about Trendelenburg test kan. If patient positive Trendelenburg, they should have myopathic gait. It shows a proximal myopathy rather than distal myopathy. So patient with proximal myopathy, they will have myopathic gait. Patient like HMSN kan, like Charcot Marie Tooth, they don't have myopathic gait because the problem is with proximal, with distal. And patient with myopathic gait, they can do tiptoe very well. Okay, most of them can tiptoe very well because they don't have problem with the distal. But they will have usually myopathic gait associated with Gower sign because they have proximal thigh proximal weakness. Foot drop, okay, biasanya most of the time foot drop is because of lower motor lah. Lower motor problem, and it's associated with sensory. Okay, next. You also got this in patient with sensory problem, especially pressure and also pressure lah, loss of pressure, nociception. They can have what you call it, a forced stepping, like forced step. I can't remember the name actually. Like it's forced walking. You know, like patient with diabetic kan, dia ada glove and stocking distribution loss of sensory kan. So this kind of patient, they will have like very forceful step. Spinal cord again. Okay, this is very important. Look for the spine. Next. Okay, including when you assessing the spine, you have to assess the anal tone also. Anal tone, assessing the bladder bowel control, and definitely the sensory. Okay, patient with gait problem, especially if you suspect this is something lower motor or spinal in origin, you have to assess the sensory. It's most of the time it comes together. The distribution should follows. The myotome and the matum should follow. Especially if it's spinal problem. Okay, I think that's all.
Okay, I think there is a group now, they have another teaching activity. They can go. And the other, if they have any questions for Dr. Alawi, answer. So my advice, if you don't have any questions now, is the gait in children is different from adults. Okay, So we need to present. I know that we have a good video. I didn't show, but we need to present the attacks gate. Okay, the spastic gate, which you wrote it as the cesarean gate. Other gate, which is even hemiplegia in the children. We have what is the name of the hemiplegia gate? You must put it. Okay, as a pediatric. I didn't show the video. You can just revise it. Is it only for adult or for children? If it is for adult, try to put it for children because we have our different gate, like the waddling gate. It is very common to see it in children. Okay, like that. Okay. So we need to adjust all this. Is it the last presentation today?
Yes, doctor.
Okay, that's fine. Dr. Alawi, do you need anything from the remaining candidate?
I think that's all. 'Cause I need to go as well.
Okay, that's fine. Thank you, and see you inshallah again with the next session of teaching. Assalamu alaikum wa rahmatullah.
Waalaikumsalam. Thank you, doctor.
Thank you, doctor.
Thank you, doctor.
Waalaikumsalam.